Today's podcast is about one of the fundamentals of intensive care practice, caring for the injured brain. It's important to remember that the brain can be injured by many processes, not just traumatic brain injury. It can be caused by central infection, hypoxic ischemic injury, toxicities, and various encephalopathies. One of the most important concepts is that of primary versus secondary injury. The best example of this is in traumatic brain injury. The primary injury occurs at the time of the event. The secondary injury is what occurs in the subsequent care and is hopefully preventable. Another key concept is that of supply-demand balance. Clearly, we need to maintain nutrient supply to the metabolizing tissue and facilitate waste removal. Finally, the issue of brain swelling is important to keep in mind. Worsening brain swelling impacts directly on supply-demand balance, contributing to secondary injury. The subject of secondary injury is interesting. At least in traumatic brain injury, there's a clear link between hypoxia and death, and hypoxia and poor neurological outcome. Similarly, there's a link between hypotension and poor neurological outcome. Whether this is cause or effect or just association is hard to tell, but clearly it makes sense to avoid both hypoxia and hypotension in caring for patients with injured brains. The metabolic needs of the tissue must be met. On one side of the coin is perfusion, but also content of blood. We need to ensure that the blood is full of oxygen and full of glucose. On the other side of the equation is demand and cerebral activity. The brain is perfused through vessels, and recall that Persuil's law describes the flow of blood through a cylindrical tube. In this equation, flow is determined by the difference in pressure from one end of the tube to the other. In this case, it's known as cerebral perfusion pressure and is defined as the mean arterial pressure minus the intracerebral pressure. K is a constant and reflects a number of factors including the radius, length of tube, and also the viscosity of the blood. In reality, these things are not constants, but for the sake of this argument, we'll consider them a constant. Therefore, there are three determinants of brain perfusion: intracerebral pressure, mean arterial pressure, and the constant. Another key concept to grasp here is that the skull is usually a fixed volume. Within that space is blood, whether it be arterial, venous, or extravascular, brain tissue, and CSF. Initially at least, as the volume of one of these substances increases, the volume of another must decrease. For example, as this hematoma expands, the brain tissue gets squashed and the CSF may be forced out of the skull. This effectively limits the change in pressure within the vault. However, there comes a point when there can be no further compensation and the pressure begins to rise. This occurs in an exponential fashion, as shown in this graph. This has two important features. Note should be made that as the pressure starts to rise, for relatively small changes in volume, the pressure rises dramatically. However, the converse is also true, so that a relatively small change in volume will lead to a relatively large drop in pressure. This is important when considering management options, as discussed later. So how do we manipulate intracerebral pressure? Sedation and removal of noxious stimuli such as pain is important. Keeping the head elevated to 30 degrees will help to improve venous flow from the brain, as will removing tight tube ties, loosening very tight fitting collars, keeping the head midline to avoid buckling of the internal jugulars, and reducing PEEP. Sodium control is also important. Sodium is the major extracellular ion and controls water flow across the membrane. It's important to keep sodium in the high normal range. Various osmolar therapies such as mannitol and hypertonic saline have been suggested. While good in theory, in practice these therapies have been found to be harmful rather than helpful, for maintenance therapy at least. Finally, beware of hydrocephalus, which can dramatically increase intracerebral pressure. Well, what about the box? Can we decompress it? Clearly, if the patient has a large blood clot, such as an extradural hematoma, this can be removed. Similarly, if the patient has an intraventricular pressure monitoring device present, then a small amount of CSF may be removed. As we described earlier, even a small volume removal can have dramatic impact on the pressure. What about opening the box? Well, there has been a theory of decompressive craniectomy. This in theory gives more space for the brain, which may in turn reduce the pressure. Usually this has been done through a bifrontal craniectomy. Unfortunately, the results of the recent DECRA randomised controlled trial found no benefit. As I mentioned earlier, the role of mean arterial pressure is hugely important in determining cerebral perfusion pressure. Normally, of course, the flow of blood to the brain is not dependent on mean arterial pressure, at least within the physiologically normal range. Instead, the brain is perfused largely dependent on factors related to its metabolic needs. However, in injury, this relationship is significantly altered, such that the blood flow to the brain is heavily dependent on MAP, if not linear in nature. This, of course, has profound implications. A drop in MAP means a drop in brain perfusion. Well, how do we manipulate the MAP? Well, obviously there's fluids and vasopressors. Mannitol and hypertonic saline, in addition to their hyperosmolar effects, may recruit fluid into the intravascular space and increase MAP that way. Current guidelines suggest that systolic blood pressure below 90 mm of mercury should be avoided. Similarly, a cerebral perfusion pressure of less than 50 mm of mercury should be avoided. In the absence of intracranial pressure monitoring, this may be difficult, but clearly a MAP of 70 to 80 mm of mercury is required. It's apparent that aggressive attempts to raise central perfusion pressures to greater than 70 mm of mercury are associated with harm. Well, what about K? Can we manipulate the constant? Well, there is in fact a way. Hypocapnia will result in constriction of the blood vessels, which result in a reduced blood flow to the brain. This will in fact reduce intracerebral pressure. However, will also compromise supply-demand balance. Some studies have been performed on various vasoconstrictors and vasodilators, depending on the patient's condition, though these remain somewhat experimental. Manipulation of the viscosity of the blood has also been attempted, and this is known as hemodilution. This has most widely been applied in the setting of subarachnoid hemorrhage as part of the Triple H therapy. Of course, with time, the injury to the endothelium will resolve. Clearly, reducing metabolic demand reduces the strain on the supply. Sedation is important, and in addition to that, paralysis may reduce some metabolic demand. Preventing seizures is definitely important, as seizures can increase the cerebral metabolic rate by over 500 times. Maintaining normal glucose levels is also important, as is preventing fever from occurring. In refractory circumstances, thiopentone can be used to completely suppress metabolic activity. Well, what doesn't work? Well, steroids have been used in a number of studies and have not been shown consistently to provide benefit. Induced hypothermia has been very successfully applied in hypoxic ischemic injury, but not in other settings. Indocid and other anti-inflammatories have been promising, but unfortunately have failed to deliver, and routine mannitol and hyperventilation have not been shown to be effective. So in summary, what are the fundamentals? Clearly we need to avoid hypoxia and avoid hypotension, and ideally treat these as soon as they are detected. Early protection of the airway to prevent aspiration and consequent hypoxia and to control hypercarbia are also very important. Implementing brain protective strategies where they're available, specifically focusing on reducing intracerebral pressure, supporting mean arterial pressure, and reducing metabolic demand are the keys to reducing secondary injury. Hyperventilation and mannitol are used when signs of herniation are present, as a bridge to alternate therapies. Finally, early consultation with neurosurgery is clearly important. Thanks for taking the time to listen to this podcast. If you enjoyed this presentation, why not visit our websites at www.crit-iq.com and www.crit-nurse.com. Critique is a leading provider of online educational resources for critical care clinicians. No matter what your level of experience or training, Critique has something for you. Our regularly updated journal club and podcast interviews will help to keep you up to date with the latest news, while our Echo database and modules teach you new skills. We even have a series of new apps to help you on the go. You can even join our open access blog and have your say on current topics. Critique, critical for life.